Thank you, Anna, and thank you everybody for being here. This is so exciting. I want to start just by thanking this incredible panel, who I did not tell to all wear navy blue, but clearly that is the health commissioner uniform. I just want to thank all of you for being here today and taking time from your very, very, very busy jobs to be with us. I can't think of a better way to start this symposium in the next 2 days than to hear about urban public health on the ground, from the very people who are practicing public health every single minute of every single day. And my hope is that aside from what's going to be an interesting and exciting hour and a half, that this session will help us frame our thinking and grounding as we move through everything else. Because whatever we come out of here with at the end of the day on Friday, it all tracks back to here, what we do every single day in public health to make people's lives healthier. So I will introduce the panel in a moment, but just to give you a little bit of lay of the land, we'll spend about 45 minutes or so with some questions that I have for our panelists. We will then have about 20-25 minutes for questions from all of you, so start teeing those up in your brain as we go. And then for our last 10 minutes, I'll do a little wrap up and a final question for our panel. So joining us today, to my right, is Marvia Jones, who is director of the Kansas City Department of Health. Thank you, Marvia, for being here. Next to her is our own Palak Raval-Nelson, who is the health commissioner for the Philadelphia Department of Public Health, and I have to say also an alumni of our school. And actually, while we're doing that, can all the alums in the room just raise their hands? Because we have a lot, and these are now people who are working and studying public health throughout the city and the country, and we're really proud to have them here. Raynard Washington, who is the director of the Mecklenburg County Public Health Department and chair of the board of directors of the Big Cities Health Coalition, which we'll hear about more in a moment. And Dave Margolius, who's the director of public health for the city of Cleveland. So with that, Raynard, I'm going to start with you. Can you tell us a little bit about the Big Cities Health Coalition, what it is, why it's important to have a coalition of urban health departments, and a little bit more about what folks should know?
Sure. Good morning. Great to be here with you all. The Big Cities Health Coalition is a collaborative effort across the 35 largest cities in the country. We bring together the health commissioners or health directors from those cities to essentially work alongside each other, to learn from each other, to complain to each other, as well as to think creatively how we tackle difficult urban health issues in our cities. We as a coalition, the 35 of us, represent about 20% of Americans, and so we also use our voice together to be able to advocate for issues impacting health in big cities. And then working together, we also look for opportunities for us to be able to partner, to do things together as cities, to replicate models that work in one city and another. We get together as a team about twice a year in one of our cities in the nation's capital once a year. We also visit our elected officials while we're there. And then we work a lot to engage with the administration to make sure that, again, the interest of big cities is represented in what's happening in terms of how policies are being made and how funding has been allocated.
Great. And the rest of you, any additions to sort of what role BCHC plays for you or how it helps enhance the work that you do on the ground?
I'll add, and thank you, great to be here, appreciate this opportunity. As I represent Kansas City, Missouri, which is a bluish city in a red state, or a more conservative state, it has been helpful to have the Big Cities Health Coalition who can speak on behalf of some of the things that I and my health department might espouse or believe in, but we cannot necessarily get that traction in our state. So it's been helpful in that regard.
Terrific.
And I think for me, first of all, thank you so much. It's great to be here. I think for the Big Cities Coalition, so I had started working on Big Cities when I was our environmental health services director for the city of Philadelphia. We had an environmental group, and one of the biggest advantages to being in a group like that is the networking opportunities. As Raynard and Marva were saying, having the capacity to reach out to someone, either whether it's a new public health challenge that you're facing in your city to get guidance or wisdom, or just overall to have those unofficial connections and network to say, this is what we're experiencing, this new emerging thing is happening in our city, have you thought about it for your city? Or it may end up coming to your city. So having that capacity is really very helpful. And I think the best part is it's all grounded people. So being able to pick up the phone and just talk, and that goes, you know, to the efforts of Big Cities Coalition to provide that framework.
Anything else, Dave? You're good?
Yeah, I mean, I think for me, there are only a few dozen people in the world who knows what it feels like to get a call from a mayor saying like, hey, why is there a homeless person on you know, this corner in front of my office? And so that's that group here, because we have that shared experience.
Great, thank you. So there is no shortage of public health issues that you are all dealing with, and the list just grows and grows because we get more things and we still have all the old things. But I want to ask, sort of, in your jurisdiction, in your job, is there one particular thing, could be overall, could be right now, could be this week, that sort of keeps you up at night? One particular issue. And one, just one. Dave, I'm going to start with you.
Sure, well, every night it's something different. In general, it's usually like, why hasn't that contract been signed by the, you know, whoever? But I would say in Cleveland, we have the highest rate of lead poisoning in the country. Our lead poisoning rate right now is about 1 in 8 children test positive for elevated blood lead level. The reason is because of lead paint. And it's such a deep challenge in Cleveland. It is the #1 cause of lead poisoning in the country. But as you all know, studying what you do and doing what you do, most of the country has moved on from this problem. I mean, this is in their rearview mirror, just like some of our other health issues like smoking, drug overdoses. Folks are just moving on. And so in Cleveland, we've got all these old houses full of lead paint. Even when you talk to members of the community, when they hear about lead poisoning, they think about Flint, Michigan. Our lead poisoning rate is 2 to 3 times higher than Flint, Michigan's ever was.
Wow.
And so what we're doing about it is we've got to fix as many old houses as possible. We've got to build as many new houses as possible, and we have to demolish as many old houses as possible without dislocating people and increasing our homelessness rate and affordability crisis. But it's a lot of work, and going back to these conversations with the mayor, and when I bring the issues to the mayor, who's a wonderful person, future leader of country, all these things, he'll say things to me like, hey, so what, by next month, how much will our lead poisoning rate decline? Like let's figure out an improvement plan here right then and there. And as difficult as those conversations are sometimes, I mean, he's also right. Like, we need to be focused on improving year over year our lead poisoning rate, and we've started to see some of that over the last couple of years, but it's really challenging.
Raynard, we can just go down the line on this one.
This is like the most unfair question for anybody. To find
you knew it was coming. And
one issue to talk about. I think I will, just for the sake of variety here, for us right now in Charlotte, we are contending with a surging rate of congenital syphilis, which of course is happening not just in Charlotte, but across the country as syphilis has reemerged in communities. But for us, the rate of growth in congenital syphilis cases is so extreme that we are pretty much all hands on deck now to deal with syphilis. And of course, you guys know it's an STI, so it is tied to sort of overall challenges with sexual health that we're dealing with right now. And so it really is not just congenital syphilis, it's this broader issue of addressing sexual health in our community, both as it relates to HIV as well as other STIs. And so we have launched a pretty aggressive strategy to be able to ensure that every pregnant woman in Mecklenburg County is tested 3 times during pregnancy, offering home-based treatment as well as care management for high-risk pregnant women to ensure that we are able to turn the tide. We went from having essentially no congenital syphilis cases to, I think last year we had 25. And as you all know, congenital syphilis can lead to stillbirth and obviously lots of complications at birth. And so we are pretty much all hands on deck right now. We have a task force that we've convened to address specifically congenital syphilis. And of course, we're dealing with a penicillin shortage right now, which is the only approved treatment for pregnant women with syphilis. And so really all hands on deck right now because in our community we have like fewer than 50 doses of penicillin. So the margins here are really short in terms of our ability to be able to respond. And so lots of effort being placed on that today right now.
So I think, as my panel members have said, at any given time in this role, you could get a call about just about anything, whether it's a contract, whether it's something associated with what you do or another department does, and especially because I've put my tagline at the bottom of every email because I want folks to know that public health needs to be present in all settings. It's public health touches everyone's life every day. So I've invited this in, right? So everybody contacts me. But I think the thing that keeps me up at night, having been in the realm of public health for more than half of my life, the reason why I got into public health was the capacity of being able to remove expired infant formula in a bodega in Kensington and fell head over heels with this profession. The thing that keeps me up at night is not being distracted by all of the recent occurrences of the day and zoning in on children's environmental health issues. That is at the center of me. I'm an environmental scientist by practice, so the things like looking at our lead poisoning rates, coming up with comprehensive policies and enforcing laws. We have a lead-safe law about rental properties so that parents are not paying for their children to get lead poisoned. We can talk offline if you'd like about how we decreased our lead poisoning rate in our city. We too have very old infrastructure. But things like asbestos in schools, kids should not have to battle, neither should people that work in a school. The night custodian shouldn't have to worry about mesothelioma 20 years from now because there was a roof leak and they're cleaning it up. So comprehensively looking at those things, looking at our air quality, working with our water department. I'm a firm believer that public health is a basic human right and that everybody's entitled to good public health. So also working in this realm and space, working collaboratively with departments so that we can make sure that everybody has access to water and food. So it's really, those are the things. I worry a lot about our kids in our community and whether or not they're getting everything that they need, not just to survive, but to thrive. Because one of our basic indicators in our health department in our city is years of potential life lost. And we want everybody to get to age 75 if that's the end goal, and past 75 hopefully, but to be thriving, not to be suffering. So really focusing in on the facets of children's environmental public health.
Great, thank you. Marvia.
I had a staff member about a couple months ago who has 2 young children. One's an infant and one is a toddler. And she came to me after some of the changes with the Vaccination Approval Committee, the ACIP committee, and the changes that were happening there. And she said, I am afraid that our health insurance at our city is not going to cover the vaccination for my children if the schedule is changed. What is that going to mean for our kids, for city staff, as well as the rest of the families in this city who aren't going to be able to get what they need through their insurance if insurance changes based on these shakeups? And that, for me, that moment just kind of heightened my concern about where we are, where the agencies and the standards that we've depended on for so long. And, I got into public health in 2012. And, I had these institutions, the CDC, the HHS, and, we knew they set certain policies and certain standards that the state and the local departments could lean on. And now to be in a position where I'm still having to do things at the city level to ensure residents' health, but I don't have those same institutions to lean upon. And that fear is very tangible, both at my leadership level, but as well as just rank and file staff who find themselves at a crossroads and are really just concerned about what the future holds. And so that's something that keeps me up, is what happens when people no longer have faith or trust in institutions that we have learned and we were taught to trust. Where are we now? Where do we go from here?
Okay, thank you. So I promised this panel would not only be challenges and hard things, right? So some of the greatest, probably all public health innovation happens at the local level. So talked about your challenges. Tell us all a little bit, some public health innovation that you feel proud of, that you have done and seen happen locally. And it can be a big thing, it can be a little thing. Raynard, I'm going to start with you.
I knew you were going to do that. This is not necessarily a huge innovation, but it's something that we are incredibly proud of in Charlotte. A couple of years ago, our state legislature passed what was called a Parents' Bill of Rights, and it had a lot of intentions, but one of the unintended consequences was required students who receive basic public health screenings in schools to get parental consent before they could get those screenings. As you might imagine, getting consent might sound easy, but it's not. And so a large proportion of kids did not get their consent signed. And we saw about a 60% reduction in screening. So these are dental or oral hygiene screenings as well as behavioral health screenings that are done in school. And so at that, prior to the Parents' Bill of Rights, we were screening almost 100% of kids in elementary school, which created opportunities for those kids, if they had something going on in their mouth, to get to a dental provider. And so we have been working for the last 2 years to, one, get the legislature to change the policy, which we have not had any success with, despite the evidence that it clearly is causing harm. But we have been working with the school district to basically integrate a single consent form at the beginning of the school year for basically everything, and to make it automated. So that parents could literally just click one button and get consents. And so sounds like a small thing, but really a big deal to be able to get almost back to 100% consent at the start of the school year this year, which just started last week. And very excited to be able to wrap around that now a mobile dental unit, which our department was able to acquire using ARPA funding, the American Recovery Act. And so now the mobile dental unit is able to actually pull up at a school and not just do screenings, but they're able to deliver dental care to those kids who may otherwise not be able to receive comprehensive care. So the unit is outfitted to do everything you can do in a dental office, including has an X-ray machine and everything you would need to do comprehensive dental care on there. So really excited because those kids having consents mean that they'll get their vision screenings, dental screenings, and behavioral health screenings in school without having to go to a provider to get those.
That's terrific. Dave, I'm going to jump to you.
Okay. So a couple years ago in Cleveland, we had a growing challenge with homelessness, specifically unsheltered folks who are living in campsites, sleeping bags, out on the street. A lot of the different benefits and programs that were available during COVID had started to basically sunset. And so people look to the city to do something about it. And the classic approach that cities have taken to homelessness is having the police go and saying, all right, you can't camp here, or just try and hide so that folks don't see you because you're making them uncomfortable that you living outside. The county runs our Office of Homeless Services where I am in Cleveland, so it's a separate government agency, and their focus was on sustaining the shelter system and building permanent supportive housing, which is really important. But no government agency was taking the lead on our unsheltered population, folks spending the night outside. So we started a program after surveying the best practices across the country, found in Houston that they had reduced their unsheltered population by like 50%, from like 10,000 to 5,000, by going to folks in campsites and paying for an apartment and a case manager. not that crazy an idea, but it wasn't happening in that many places. And so we started doing that. Good news is in Cleveland, we only have like 300 people who are spending the night outside, but through the Home for Every Neighbor program in the first year, we've housed almost 200 folks, and we've got it renewed for now sustainable funding going into the future. So it's our Home for Every Neighbor program we're really excited about.
That's great.
That's nice.
Marvia.
In 2022, when we had come down from the highest peak of COVID-19, severe complications and deaths and that sort of thing, in my municipality, we had some concern around trust and, do people trust public health? My predecessors and just our agency had to shut down some businesses and, obviously our schools were affected as well. So we had an interesting vibe that was not uncommon across the country where people were kind of tired of hearing from the Kansas City Health Department. And so what we instituted was a community wellness or public health ambassador program. And this is where we had everyday folks who are they have day jobs, they have kids, they have all sorts of things going on. But once a month, we bring them into the department for about 4 hours. We have a morning session, and then we have a night session for folks who need that time frame. And we pay them to just come and listen to all the information about our health department. We talk to them about lead, and we talk to them about sexual health, and we just give them a full indoctrination. That's the bad word. The full
You're amongst
education about public health and what we do on the ground in their city. And so we are now in our 4th cohort. So we have had over 200 folks come through that program. We pay them a small stipend just to be a voice in their networks, to go to work and talk about, lead and how you can get your house surveyed for lead and get your doors replaced or windows. Talk about sexual health and talk about HIV and help us destigmatize, because people don't always want to hear from Marvia on that or my team. And so we have seen folks who have been tremendously proud to serve in this capacity, everyday folks who didn't think they had a special role, and they wear this little cheap pin that we found on sale that we made up for them, that they wear that really proudly and they feel like they are a part of public health. All walks of life, all folks representing all parts of the city, various points on the political spectrum, multiple languages. It has just been a very fulfilling program, and to now be in our 4th cohort, I'm really proud of that.
Wow, that's amazing. Palak.
So I'm going to kind of talk about, I'm pivoting to a different program. So one of the things that we know is housing insecurity is a big health issue. Housing, safe and healthy housing is a big issue for children and everybody else. One of the challenges that our city was facing, and the mayor's announced the Home Initiative, which is pumping $800 million into creating homes, whether adding homes or preserving homes. And one of the challenges, so if you're living in a home and let's say your parent or whomever died, they never had a chance to transfer the deed to you. So now you're living in a property, you're paying all of the bills, but the property's not in your name. It's a tangled title, okay? The person that died, you can't get the death certificate, you can't get the records, so you can't apply for any of the programs that we're rolling out to either repair the home at a low cost or to apply for a home equity loan or anything like that. So you're pretty much stuck. You can't even qualify for the HUD funding to have your property remediated for lead because it's a tangled title. So this is a bit, I'm not going to say out of the box, I prefer circles, out of the circles. So we realized that the connection, our records commissioner, our records department handles titling and tangled title. Well, the health department has a medical examiner's office. We have the death certificates. So, we're kind of having this organic conversation during a leadership meeting, myself, the records commissioner. We've realized that, so then I go back to our medical examiner and I say, what can we share, what can't we share? So we have just recently put together an agreement which protects all of the data and all of those parameters, but essentially, if someone goes to the records department and says, I'm in a home, I'm in a tangled title, I need help, how do I do this? The records department is able to access the information about the death certificate, verify, and people can move on without, extenuating red tape, extra costs and everything. So it's brand new, it's innovative. You wanted innovation, it just started. We're going to, I hope I get a chance to kind of report back on the progress, but this is an example as we are facing so many crises in public health, and crisis, can be opportunity in public health. How do we collaborate and connect with, of all the places, the records department? They're very important, don't get me wrong, but how do, public health and the records department working together to create a scenario and a situation where we can actually improve housing security for Philadelphians?
So wow, without even planning it, this was a perfect example of both big things, but how sometimes the small things, linking records, universal screening, can make a huge difference day to day. So thank you for that. So we started talking about it a little bit, but it's really hard to talk about public health this week without talking about vaccines. So trying to keep this question manageable, because there's so much one could say. Given the, I would say, chaos and confusion, my generous terminology, about what's happening at the federal level, what does that mean for all of you on the ground as we head into COVID vaccine season, flu, back to school, childhood vaccine schedule? You all have a sort of an annual thing that you do every fall. How is that changing, and what are you gearing up to do? And Marvia, I'm going to start with you this time.
I'll try to keep the mood light. I think the hardest part about this, and the thing that is most frightful for us, is just not being able to give people a straight answer. I still have folks asking me, hey, when can I come and get it? And is it going to be the updated COVID vaccine? And you might say one thing on Monday, but by Tuesday or Wednesday, the news has changed. I believe that occurred in this past few days where suddenly, okay, this is a go, the new COVID vaccine. So I don't feel as solid in the things that I share with my community. I don't feel like I can stand, because next week, I don't know what's going to be tweeted out or what's going to be put out in a media release, and then I look less competent to my community. So that's one kind of thing that is hard. We're watching in Florida where they have decided to no longer, or they're talking about, I don't know where it's for sure going to go, but talking about removing the requirement for back for school or childhood vaccines. We sometimes see these things spread across states, so I'm now worried about what that could mean in Missouri. If we were to be put under such an order. And so it just changes your ability to really give people expert advice and tell them where things are.
Great. Palak?
So I appreciate that. And there's, you wake up sometimes in the middle of the night and, the path of a hurricane has been changed by a Sharpie, right? It doesn't change the hurricane. It doesn't change the actual path, okay? Public health is based in science. Vaccines save lives. Vaccines keep people from getting polio, measles, COVID. I still remember when we had the National Guard here administering COVID vaccines and trying to get staff in, and our password was the wheels on the bus go round and round, because we had to come up with some sort of a strategy to work with them that was consistent. So we know the science, public health, hundreds of years tell us that vaccines save lives. So while we can, get into the debate and everything else, as the health commissioner of the city of Philadelphia, I want to stay local and focused. Our message is, get vaccinated. If you're not sure what dose you should get or what vaccine you should get, prior to all of this, what would you have done? You would have asked your medical provider. You would have said, hey, I'm feeling this kind of way. Should I get the COVID vaccine now or should I wait, right? I'm not feeling my best. I know the vaccine's going to knock me out. Should I get it now or should I wait? So following that same strategy, as the health commissioner, the other role is about procuring and making sure our city is prepared for what we need. Okay, so that is also about fortifying the staff within. It's also about having the conversations internally about what is the science, what are the experts, and a bunch of them are in this room right now. What are we agreeing to that needs to be done? Because that's what we need to do now, okay? We have to focus on the truth and the reality, which is vaccines save lives, and we have to be there. And then we also communicate up through the administration and the law department to figure out what are the things that we can do, what are the things that, you know, that we need to fight on and fight about to move forward. So that's it, focusing locally, being laser focused, because I don't want people getting sick in the city because somebody's having a debate.
Raynard?
Yeah, I mean, I think that's right. Nothing has actually changed, and so we continue to try to reemphasize that message locally, and ensure people recognize that while there is a lot of news, lots of headlines, lots of tweets, lots of noise, the reality is that nothing actually has changed. The science around measles, mumps, and rubella vaccines is essentially what it's been longstanding, and I think the unfortunate realities that are playing out on the ground that we are all seeing in our cities, where we're seeing cases of measles and infections that we have long been able to contain. As you all probably saw, the large measles outbreak in Texas. We had another case of measles in North Carolina earlier this year. As those realities continue to march forward, we will have to learn some hard lessons, or some folks will have to learn hard lessons who believe that things have changed, and in fact they have not, and the science is what it is. There's a lot of discussion, I guess, to zoom out a little bit, in the public health community at large about, you know, losing institutions that we have relied on. What do we do, right? And so I do think there are a lot of folks up here and in this room who are having conversations about, you know, ensuring that we do continue to have recommendations that are based in science, whether they come from the CDC or not, but to ensure that there is a public health infrastructure in this country that makes solid recommendations that are not politicized. And so there is some optimism, I think, in some of those discussions that are happening with our clinical partners on the side of medical societies as well as the public health societies. And so I am encouraged that at least those groups are coming together in a way that to build coalitions to ensure that there is solid science, even if we cannot rely on the federal government to do that.
Dave?
Yeah, so 10 a.m. RFK is going in front of the Senate or whatever, and I'm just hoping he says something that insults the president inadvertently so he gets fired. Things will be a lot better.
There is that.
It's strange what we hope for these days, right?
Yeah, in the first term they did a lot better getting fired, you know, more quickly, and so.
It's a new fantasy football game.
Right, exactly. That's what we're hoping for today.
Okay. We'll tune back after the break, see what's going on.
Right.
So switching gears a little bit, I want to talk a little bit about data. We have a couple sessions that focus on that. So short, and then we'll have a follow-up, but what are some of the greatest, I'm not going to require you to only say one, data challenges in local public health? What data thing is just the hardest to crack? Palak, I'll start with you.
So I think the biggest challenge when it comes to data is identifying an appropriate source and then really grappling with the associated data, navigating the data agreements, convincing partners to share. I think that this fear-mongering that's happening on a national level, people want to hold on to we've all of a sudden gone from, you know, abundance to scarcity. So people want to hold on to the stuff that they have, and I think that's anti to what's going to help us. So collaborating, being mindful of what data is shared and how it's shared, you know, really looking at it from a democratic standpoint of if the data, public health data, should be used to help people, right? From a population health standpoint, if we shift our frame and say, okay, just like the records, death certificate type of thing, you know, how can we use the existing data without violating any protections, ethics, and use it to promote good, sound public health policy to make things better overall for our local jurisdictions?
Dave.
I would say the biggest challenge in public health data is that it's too slow. So I came from the healthcare quality improvement world. It was the leading quality improvement for a safety net system in Cleveland. And you could make a change across the system, and all of a sudden, that next month, see the colorectal cancer screening rate start to increase. But in public health, as I alluded to with my conversation with the mayor, those types of changes are much harder. And so a few years ago, the CDC did this great set of recommendations called the high impact, the high five, high impact in 5 years. And so it was, what are the interventions that you can see public health outcomes improve within 5 years, which is about the right time frame for an elected official to get excited about. So, which is exactly what the CDC report said. And the CDC does all sorts of cool stuff. So, yeah.
Marvia?
Yeah, kind of related to what Dave just mentioned, it's slow and it's also not always available at the level you need it. So I can get decent state level data. I can see what Missouri overall, what the rates of, different things might be, heart disease and those sorts of things. But if I wanted to look at Kansas City, my jurisdiction, it's going to take a lot of requests, some supplication, just some really, and it's going to take me a couple years. It's going to be a couple years in the arrears for me to get. And so it's not always available at the level you need it.
Yeah, I would say two things. The first one is, public health data really is kind of bad. So we get these points of time of a person's life when they get a disease or they die or they're born, but we never are able to actually follow what's happening to look for these kinds of improvements Dave's been talking about over time. We don't have the whole picture, so we always just have a snapshot of something, and it's really difficult to think about what that means for an individual and a whole community with just the snapshot. And so our inability to be able to link various data sets together to create a more comprehensive picture is one of the biggest barriers I think we all face, as Palak was mentioning earlier. Getting a data use agreement signed between two agencies can take multiple years, and then it's for data that's 5 years old. So it's this is not helpful anymore. So that's my first big issue. The second one I would say is, our technology also is not great, and so the systems that sit behind most public health reporting is very dated. It's variable across cities, it's variable across states, and it's variable across federal agencies. And so that impacts the speed, it impacts access, it impacts the ability to connect information across them. There was some really amazing work happening at the CDC to really try to rebuild the data infrastructure that is used for disease reporting in this country. Unfortunately, that leadership is not there anymore as of last week, but the work Jen was doing was incredible. And I hope that at least the framework is there and there's a foundation. I hope that we're able to continue to make momentum there, because the systems are one of the largest sort of barriers to our ability to be able to have real-time, accurate, appropriate data.
Right. So given these challenges and constraints, what is the best way to use data for decision making? And what do we all who are researching, studying, and many of your academic partners, what do we need to know about what you need and how we can best support you to use data in decision making? I know that was a lot in there, so grab onto whatever you can. Dave, I'm going to start with you on this one.
Okay. So I would say, I think the most important thing you all can do in terms of data is just expand your scope of what you're looking at. And so an example is, think of public health, vaccination rates, life expectancy, a number of other outcomes that are really health-focused. You took classes on them, but in Cleveland and Philadelphia, and you heard about this, housing is so important for health. And so there is a data set of how many new home permits have come out of each jurisdiction across the country that HUD maintains. And so there are other data sets like that that are outside of what we classically think of as public health, but everything is public health. So just expanding your scope of where you're looking for data.
Great.
I'll jump in. So to that point, I think when it comes to decision making and data, sometimes, as my colleagues have said, data is slow to have. We have data from, the report looks great, but now the tables are from 2 years ago. Yeah. So trying to make some fairly quick decisions during my time here as a student at Drexel's School of Public Health. My professors pushed me very hard to think about other sources of data that I could use, because the data that I needed for my dissertation was not as accessible, and I would never have finished. So I keep that in mind, and that was using unobtrusive data measures, right? So to the point that you're talking about the housing data, expanding our lens of where we're pulling data from. So if I want to know if a particular area of the city of Philadelphia has high vaping sales, right? I could monitor people, I could do questions, I could look at other things, or I can use some of our other capacity and regulatory capacity and tool sets that we have and say, you know what, there are 25 corner stores that sell these products in this neighborhood. Revenue department, can you please pull their receipts of sales for me? And I can very easily, with some of the smartest EPIs on the team, FYI, shout out there in the audience. I can very easily take those receipts and say, hey, can we compare how many vape products were sold in comparison to other things? And then we can pull the same sort of receipt data set for another neighborhood, maybe a less minority, more affluent neighborhood of the city, and do a very quick and dirty comparative analysis using completely unobtrusive data sets that don't traditionally require, because we're not getting any HIPAA protected or any other such information.
Great. Marvia?
Yeah, y'all, I think we have, and I say this as someone who worked in academia and research, but I now see that we were a little bit wrong-headed. We have to change the structure and the speed at which we do our research and collect our data. So if you're working on a project and you are working with actual residents who are utilizing a service, or you're doing some sort of longitudinal study of them, and you're trying to see how these types of interventions impact their lives, I know you're collecting data on a number of variables. Y'all know we load that variable list up. You know everything from where their kids go to school, to what kind of diet they have, to how many times they go to a doctor's office, to how many cigarettes they smoke, and how many vapes they've tried, and how many flavors. Like, you already have that. But what we do is we collect all this stuff, we study for it for years, and then years later we write about what we saw. That does not help me. That does not help me when I have to look at a study that's 7 years old. The data were collected 7 years ago. The context, the culture have changed, the products have changed, the environment has changed. And so we need more of that short-term reporting. This is less about making sure that we get the top journal, the peak journal publications, and more about how do we get the data to the ground. I know 10 years ago we were saying, even then, the pace of research is too slow, and it's still too slow. It is not quick enough to inform policy, and so we're leaving a vacuum to where people just kind of make stuff up. Or you say you're being scholarly, and let me pull the data, let me pay for some journal databases for my city so we can use that. And again, it's very old and it's hard to draw conclusions. So please, as you're collecting data and it's on the ground, it's at the ground level, you have this information, find some sort of short form of white papers or something, still have a good quality. It can still be good quality, peer reviewed, but let's not, keep this cycle of waiting years to publish good data.
Hear, hear. Raynard?
I'm not being paid to say this, but I'm going to say be more like Drexel's Urban Health Collaborative is the best thing.
Did not set him up for that.
And I say that because when I was here in Philly at the health department, we talked, and the way that we got to sort of mutually beneficial things for us to work on together was just by talking. And I was able to say, okay, this can't be 12 months, this has to be 6 months. And Jen would look at me and she would say, okay, let me see. But figuring out kind of how can we do something that's going to be mutually beneficial? How can your research tie into the work that's happening on the ground? What is the issue on the ground that we need to tie into? Because it has a great deal of relevancy. It doesn't mean you have to stop the slow things, because you can keep doing those on the side too. But it does create opportunity, right? Talking to the health department in your local community, figuring out what they are thinking about, what issues they're facing, what information might help them, I think is the pathway way to building those partnerships where your data can be translated quickly to action that's meaningful in your own community. And again, it starts with a conversation that's broached in the spirit of how can this be beneficial to both the academic process, but also to you all as a local jurisdiction.
That's good.
Great. Everyone hear all that? I'm going to do one more question before we turn it back to the audience. I want to talk a little bit about workforce. So oops, and that's my alarm. Sorry. That's me telling us we have time for one more question. I guess right coming out of COVID, CDC invested money in public health infrastructure grants to help build public health infrastructure across the country, which so far have not been taken away, right? Not good. So I'm curious, you've done a lot of things with that. You've built your workforce, you've learned things, you've done needs assessments, and you've also all been in the job. How has the workforce changed? What have you learned, and what adaptations are you maybe doing now as a result of some of the things you've learned? Palak, I'll start with you.
Sure. So I think the biggest change, if we want to call it a change, I personally think it should have been in place forever and a day, is a focus on wellness, right? Our public health workforce, we're there in every shape, whether you're the epi or you're the medical examiner or the health commissioner. We are constantly responding to things. And so often we don't take our own wellness into consideration. We don't stop, we don't think. And coming up the ranks through the health department, I think even 10 years ago, 15 years ago, had I said, it's important to take a moment and be mindful. It's important that we have, round tables in an area where people can go and share lunch and take a breath and a break and not work through lunch and all of those things. Those are critical. And, I think and Jen, we've been doing public health for a while. So I think those things would have been great back then, but now more than ever, they are very, very important. Being connected with the staff, listening to what they need, because they're the ones that are actually doing the work on a daily basis. So if it's something as simple, our morgue staff, sitting and listening to them, their biggest component or ask of wellness was a new type of stretchers. So we got those. We found the money. We did that, right? So it's understanding wellness, but not putting my viewpoint and thoughts or public health's viewpoint and thoughts on wellness, but rather letting the actual workforce dictate and navigate that conversation of wellness.
Great. Go ahead.
Yeah, I would say ditto to Palak's. There's been a huge focus on sort of trying to rebuild, strengthen the public health workforce. After the pandemic, people were really, really burned out. Lots of distress, PTSD as a result of the response activities. And so lots of emphasis being placed there. We also have like 5 generations working at the same time. So, and I think I'm the only millennial up here, but it is very interesting managing through the different needs of those different generations. And so I think we have really been working in Mecklenburg to figure out how to ensure that how we define wellness for our employees, how we define the workplace experience meets the needs of the variety of folks that we have working with us, which looks very different, and sometimes it's challenging, right? Because you've got a group of folks who want to work from home every day, a group of folks who want to have that want to work 3 to 11 as business hours, and then folks who want to work at 7 a.m. and go home at 4 every day. And that's a small example of like scheduling, but it is a big deal for people at work, especially when our folks have hard jobs. I mean, these are jobs that are oftentimes taxing on their emotions as well as their bodies. And so I think that's a unique challenge for all of us. And that's one of the benefits of big cities is learning from each other about what are you doing for wellness and what does that look like? Right? How are you responding to the needs of your workforce when we all are constrained by the bigger organizations that we work for, which has its own sets of rules. So.
Dave?
I would say for us, what's been really exciting is people want to work for city government. People want to work in local public health. We had our previous mayor was there for 16 years, and nice guy, but did not do anything to change how government worked, how civil service worked, the hiring process. And so when our mayor came in, we've been able to break a lot of those old things, so it no longer took like 8 months from when you applied to get in the door, which is what it was back in 2022 when I started. And so we were a department of 95 people, now we're a department of 160 people, and people just are coming in the door really excited to be there. So it's been great.
That's great. Marvia?
Yeah, I don't know. I'm another millennial, Raynard, but I don't know.
Nice
Don't let
try.
don't let
Nice
the great,
try.
The great
It was a joke, I knew it.
I'm an early grader. I would say that when I first came in, and I think my cohort that came in with me, when we started, going into public health jobs, finding our little scrappy jobs, I think we had an understanding that public health work probably wasn't going to pay very well, but you did it because you had this heart and this passion for your community, and you were just scrapping. It was just kind of, I don't know, accepted. Now, I'm having people who are saying, keep your circles, keep your break room snacks, keep your training sessions and kumbayas, and pay me better. I like less book clubs, more pay raises. You know what I mean? And so I'm seeing a lot of that, and I can't see that outside of our current economic moment where we've seen inflation, we've seen, it's harder to make a living. I don't know about the other municipalities up here, but I know Kansas City is one of those that has shot up. The cost of living has shot up. In the top 5 number of cities with a cost of living increase, housing has become much more unaffordable. We have generations, the Gen Zs and the younger millennials and all these other folks who are saying, I cannot survive on this money. And so what are you going to do about it? And if you can't fix that, I don't believe you actually care about me. And so that's really hard to hear as a leader, especially when you're saying, I need to skill you up, and let's use this FIG money for these workshops, and let's do this, and do you want a chair massage?
No,
they're
no massages at work.
Constantly saying, I need more money. And so that's kind of the moment where I find myself.
I think a lot of people here can relate, so thank you. Okay, your turn. I've been asked to remind you all to speak very closely into the mic. People can raise their hands and someone will bring a mic to you. And when you ask a question, you can ask it to an individual, you can ask it to the group, and we have about 25 minutes or so. We have a hand right there in the back, first one up.
Hi, y'all. I think it's on.
Yep.
Okay. Hi, y'all. Thanks for taking the time to be here with us today. My question is on how we, as cities, prioritize public health. As public health professionals, our praxis is to prevent harm. We recognize that anti-carceral prevention of that harm is important. And my question is basically, how do we reckon with the fact that in most of our major cities, the police budget is larger than the public health budget? Especially, we're talking about public health professionals not getting paid the wages that they deserve. We're talking about, especially in Philadelphia, a city where we don't care about our population of folks living on the street. Or folks that are struggling with addiction. So how do we reckon with over-policing of our communities and spending money on that?
Oh, thanks for the question. I guess I'll just say, two things. One, elections matter. And I say that in the spirit of, there's a lot of emphasis on what happens at the federal level and even sometimes the state level, but what happens locally is really, really, really consequential for people's lives. People don't engage in local elections the way I think that they should, and it's really important because those are the folks who make decisions about what you just described, how local dollars are invested in various departments. The second thing is all of us have the challenge of communication. We have to tell the story of what public health is, what it does, what it's not. and why there is a return on the investment. That is more critical now than I think ever, is communicating that message to folks who have the ability to make decisions about how much we get paid and what positions we have in our departments. And that is the art of our jobs. That's really hard right now because we are doing that in the light of, the chaos in Washington and Florida and everywhere else. And so that is what we contend with, I think, with waking up every day trying to figure out how do I tell the story of what my department is doing and how it's doing it and how do I bring visibility to it. Because so much of what we do nobody ever sees until you are a customer of ours or we're at your restaurant door knocking, right? People don't see it until either something goes wrong. And so that is the hard challenge that I think not just us, but everybody in this room has to contend with. How do we talk about public health in a way that's not political, that's not, that doesn't seem combative, but also convinces and compels people, influences them to believe in what we all know is true.
And I think if I could add, when we do public health right, no one sees us, right? So to Raynard's point, it's not about getting into the room where the decisions are being made, it's about getting a seat at that table. And a lot of that is about social marketing ourselves and having campaigns like Public Health in Action and I can speak on myself personally, working hand in hand with the police commissioner to have the police commissioner understand the value and the importance of public health and why we need to collaborate and work together to resolve whatever issue or challenge we have and to have that dialogue, that introduction, being integrated in the conversation is key.
Yeah, my health department has a budget that is, I'll say it this way, the police budget in my town is 4 times that of mine, more than 4 times that of my own. And that is something that even staff members will bring up, like, what are you gonna do about that? Like, what are we all gonna do about that as a city? But I think that my job, and I think folks have already started this part of the answer, it's not my job to be combative. I have to figure out how to work with the police folks. And also remembering there's some nuance to what our actual constituents want. Our constituents want to feel safe. And many times the folks in your city who are most impacted by crime, violence, what have you, are the same people that we see as our primary, as Raynard said, customers. And so they don't necessarily have the same lens. They don't look through it in the same lens that we might who are in the public health room. They look at it like, I need to be better served by them. I need them to keep functioning well, and I need you to do this other thing for me. They don't necessarily see the budget arguments and all of that. They want to feel safe as well, and I, as a public health person, have to be sort of humble about that. Like, let me not make it an us versus them thing, because that doesn't really help us.
Exactly.
Right.
Exactly.
Other questions? Gina. And then you're next.
Hi, I'm Gina Lavasi. I'm Dean at the Dornsife School of Public Health here. Really happy to have you here with us. When I was hearing some of your answers, there's a lot that we talked about that has a relationship to research, but of course we're also a university and a school that's looking to train people who are ready to meet the needs of public health. And it sounds like there's needs for those public health skills and that systematic approach across organizations that are beyond public health. And there's also, in addition to different communication contexts, other technology changes that are happening that we want to make sure our students, as they graduate, are ready to address. And when I think about what keeps me up at night, it's about whether we're agile enough to meet the needs of the field in how we're training students, and whether we're opening doors in the ways that are going to help those students to reach their full potential and have voice. So I'd love to hear thoughts about what we can do that would benefit the field, that would be of service from your perspective in our educational activities.
I think if I can speak on that, having a dual role of being a student and now in this position with the health department. I think the biggest thing, and we're already doing it, but it's in a smaller subset, is having the public health students, whether it's doing a co-op or doing an intern, being at the health department, because they then can speak to some of the work that they're experiencing and the challenges that they're facing. That way it can inform potentially the curriculum and the skill sets that are needed, right? There's nothing like getting the information from a theory perspective and a lecture and doing a case study, which is quite often retrospective, but then there's a different experience if you're physically there on site dealing with, you know, hey, I need you to take care of this because we're in this situation and scenario, and getting that exposure. So I think that exposure is key, especially as we train up our CHIP or our community and our EPI folks, those students, because like the environmental folks and a lot of the CHIP folks also get that community experience and that experience from the outer world. But I think sometimes to make sure our EPIs and our data folks also have that experience.
Yeah, I would just add, I think there are a lot of things that we all have to do every day that we didn't take a class for. So dealing with people is one of them. And so to the extent that leadership skills is a part of the curriculum, I think that would be something that would be beneficial, in addition to the things you just mentioned around communication. The other thing I would add is the Summer Institute that you guys have here is another great example of something. Again, I'm not being paid for this, but to the extent that that continues to grow, there's not a lot of options like that. But I do think in terms of us to upskill people who are on our workforce to be able to go for a week or two to get some specific skills that can be tailored to sort of the work that's happening in local public health gives you guys a really great opportunity to say, okay, big cities, what are you guys dealing with and what skills are missing and what might be a topic or an issue that we could potentially add to the Institute that could be beneficial. I would say that would be something tangible.
That's good.
I would just add, so I think continue to expand the scope of the types of professions that you're looking at, the types of folks you interact with. So City of Cleveland, I enjoy spending the most time with the Department of Planning because I think everything they do is public health, right? So we lost 78 people last year to traffic accidents, either pedestrian on car, car on stationary object, or bicyclist. And most of those deaths were in just 12 streets. And it wasn't because folks aren't learning how to drive on those 12 streets as well, but it's because of the built environment. So the planning department can help invest $30 million. So I don't care if it's in my budget, right? Going back to the earlier question, $30 million to fix a street, to make it narrower, to put trees in the middle, train tracks in the middle, and that kind of thing. And that can save so many lives right away. Transit-oriented development, meaning people don't have to drive 30 minutes to their job and add that air pollution and all the other consequences that come from that. So just, the idea of having MPHs embedded in all these other city departments makes me really excited.
That's good, right? Yeah, right there.
Hi, thank you. Harvey Miller from Ohio State University. Thank you for a very interesting discussion this morning. And shout out to my neighbor to the north because you just touched upon the question I was going to ask, is that, those of us who work in public health, we tend to think at a systems level. And we think about holistic reasons why public health, for public health outcomes and holistic solutions. But city and county governments are not organized holistically. They're organized in silos. So you kind of touched upon this, David. I would like to hear from all the panelists, actually. Do you have any success stories where you were able to break down these silos in looking at holistic solutions to public health problems? Or perhaps if you don't have success stories, we could hear a horror story.
Go ahead. I was just going to actually, to my colleague's point here about the whole police and public health budget and working together, I was going to use a nuisance establishment example. So we have places and spaces in the city that are maybe a food establishment that we regulate as a health department. However, they're doing all sorts of other things. And so I think of an example, and so we've formed this group in 2019 where we do joint inspections with the police, with our licenses and inspections division. We also pull in the state because in Pennsylvania, liquor control laws are controlled by the state. And so we do these, and we created an intentional collaborative to work with them and then bring in the law department and everything. And I'm thinking about one example that could have been horrific. So we got a report while we were out on the street in Kensington that there was a place that looked like a shoe store, but that they were selling candy and soda. And there were also tips that they were selling all kinds of narcotics and potentially weapons and a host of things. But there was no reason for any of our other partners to have jurisdiction to go in there, okay? But because they were selling candy and soda, all of a sudden, that means the health department, because they didn't have a food license, and licenses and inspections could go in. And so if we could go in, but we were nervous and weren't sure, we could then have our police partners and our liquor control enforcement partners go in with us to help us. And so as we start pulling out the boxes, and the complaint was they were selling candy that was gnawed by mice. So we start looking around, and of course there are mice, and the mice are getting into the boxes, and we pop open a box to see, you know, what's in there, and it turns out to be paraphernalia and guns and weapons. And so it was a way of collaborative work that led to a success for the community because this establishment had been plaguing them.
Yeah. Wow. I like to talk about trash and vacant lots in addition to that type of work with police. For years, I had been sort of spamming our public works department with information about, like, I think some of it might have come from Philadelphia actually, about how vacant lots and spaces, abandoned lots and trash. So good work, y'all, whoever contributed to that, because it's being used in Kansas City. I'm sure y'all love to hear that. We have been kind of sending that to them. Hey guys, we need y'all to step up enforcement on these vacant lots, and we need you to fix these up and make them more valuable green spaces because that reduces violence. And so you want the health department to do, we have our own kind of community violence interruption kind of interventions, things that we have going on, but we can't do it alone. And you certainly don't want the police to do it alone. And so finally, as of a couple of years ago, 2023, our public works department started using some of the city's marijuana tax money to enhance their efforts to address vacant lots, weeds, overgrowth, beautify, institute more gardens because of the evidence that said that it has benefits for not just violence prevention, but also public health improvement in general, heart rates and some other, y'all, that was an excellent study out of Philadelphia, by the way. And yeah, so thank you for that. So.
Raynard?
It was a group at Penn, in case anybody's wondering. I was very happy to be a part of that work when I lived here.
Okay, good.
So I think there are a lot of opportunities for us to work across departments, and in our case, where we are a county, our municipality, so we have 7 municipalities in our county, including the city of Charlotte. And so we do come together to deal and tackle with issues. It's, to your point, it's not the structure, so we have to kind of build these structures, and typically we build them around issues. And so, for example, we've been having a lot of public safety issues in our downtown area in Charlotte. And so we launched a public safety task force that has the police department, it has the health department, it has our version of liquor control and enforcement, all around the table, as well as the business partners. And so everybody's playing a different role. And so it's both a success and a disaster, because I think you put all those folks in a room and start talking about people who are unhoused, and it becomes a very uncomfortable conversation, right? Because the business community's view of the unhoused and my view are very, very different. And so I think that is both an opportunity and a challenge for us as we think about getting into those, building those tables where we can work across the key partners, but also trying to figure out solutions where, to Palak's point earlier, we have a swim lane, somebody else has one, and how do you kind of do that together to be able to tackle whatever the issue is. In this case, it's our biggest success has been the illegal food vendors who are selling food and being able to work with law enforcement to move them along.
Great. Question.
Hello. My name is Sterling Johnson. I'm from Temple University. I'm just hearing you all talk about this like interdisciplinary, interdepartment kind of work that feels really powerful, and generally like everybody in here like believes in public health, and I think I'm of the belief that we actually need to go on the offensive a little bit more to show like what is happening and that it works, and because overall it does seem like we are kind of losing in some way. It just feels that way. So I'm just wondering if there are some examples of that. I mean, in Philadelphia, like right now, the Board of Health is talking about banning mobile services that are non-medical mobile services. That just means groups of mutual aid groups that help homeless people, help people that are compassionate. Right now, we're attempting to criminalize them, or at least the regulations will say they can be in one place for 45 minutes, and then they have to stop. And then what happens if they continue? Do they get arrested? So it just feels really worrying that we're in that situation. I mean, there's a Board of Health meeting tonight, right? So I'm hoping everybody here can be on that and like at least be present for it, because the people that kind of are against us and that want to say that like public health doesn't matter, or the things that people are doing don't matter, they're wrong. They're wrong, and I'm just wondering, from your perspectives, and maybe there's no answer, but I'm just saying that like we have to like I don't know, we just all have to show up for public health, and I'm just wondering how you maybe have seen that happen, how we really have pushed that, because I'm really worried for the people that are homeless and that are unhoused and what's going to happen to them, and all the people that have already died. And I mean, I'm just saying that as a person that does harm reduction work. So,
Okay.
So yeah, I'm just wondering about your response to all of that. Thanks.
Sure. So if I can clarify factually, the Board of Health doesn't regulate non-medical providers. That regulation was passed, it was done, and what we're talking about this evening is about medical mobile service providers. We know that street medicine helps us with barriers for folks that can't get to a brick and mortar space to get medical care, whether it's dental care, whether it's vision care, whether it's a host of other services, wound care, right? We have our folks, my career started in Kensington. So while the environment there has changed, there's still similar issues. As far as our folks that are unhoused, they need access to proper medical care, to proper wound care, to proper all of these things. Having a holistic approach to make sure that we don't have the Board of Health regulation that we're looking at this evening is specifically about making sure that those folks providing care are actually appropriately medically licensed and capable to do that work. There are folks that that out of the goodness of their heart want to do the right thing and help people. However, if you are learning wound care on YouTube or from somewhere else, we don't want you to compromise the health and well-being of someone that is out there that is in need of services. So the ordinance and the legislation that was passed is very, it's conflicted, I'll say that. And so from that, how do we as public health, like you said to your point, show up and be present? And in this case, instead of making lemonade out of lemons, we barely have rinds. How do we make lemonade out of the rinds that we have? And how do we do public health policy? Not just because we know that the substance abuse epidemic is spreading across our city. We know that. The data is showing us that. So what do we do? How do we protect the entire city to make sure that they have adequate licensed street medical care? And so that is the goal of it. So, I hope you are attending this evening. We will make sure that the changes that we've made to what the board will be looking at are different than what was done. And so we're really trying to make that lemonade out of lemon rinds.
We have time for, go ahead. No, go ahead.
I'll make this
Yeah,
really
go ahead,
quick.
go ahead.
I would just say also, as we're talking about kind of going on the offensive and how do we show up and how do we kind of, I want to make sure that we leave space for debate even within the field.
Yep.
We don't want to get to a point where we all assume that we all believe all the same things about how people who are unhoused should be cared for or what policy should affect them. We have to maintain that, and I don't think it is good for us as a field to just kind of believe that we all have to say the same thing. We have to leave space for that debate.
Great. We have time for one more question, because then I have a final question for our panelists. Go ahead.
Hi. Hi, my name is Kalila. And while I'm an employee at Drexel, I'm also a community resident in Blockhampton. And I hear you guys talk about partnerships amongst agencies, but I'm wondering if you have any success stories or horrors of partnerships with community organizations that are doing the same work that you, or want the same results you guys want.
Great question. Dave?
Sure, yeah, no, thank you for that. That's so important. So when I joined the health department, there was a lot of distrust from the community towards the health department. We're this terrible institution that has done so many things wrong, and look at public health outcomes in Cleveland, we must be really bad. And over time, we had done some bad things, absolutely. I think there were like 6 health commissioners in 7 years that preceded me joining. And so early on, one of the most outspoken groups that, like, against the health department is the Northeast Ohio Black Health Coalition. I had known the leader of that program, of that organization before taking the job, and I took the job, and she's like, "All right, I hate you now," and I said, "That's understandable, but what if we became friends and came to the health department, and what are your priorities?" And so her priorities were reducing our smoking rate in Cleveland due to racial targeting in menthol cigarettes in black neighborhoods in Cleveland. And so we took that on together. We weren't able to get the legislation passed that we wanted to end the sale of flavored products like you've been able to do in Philadelphia. That was overturned. But we were able to get more tobacco regulation and just partner and build awareness. And so yeah.
Great.
Yeah, we have a lot of, I think, really great successes in this space. And Charlotte, we have, in our Office of Health Equity, there is a whole community partner team that's responsible for engagement with our community partners, from the smallest grassroots organizations to larger nonprofit partners that we have contractual relationships with. They do a lot of work with them. There are training academies for them. They have small grant programs to help provide them an opportunity to do business with the county, and not just to come to meetings, but to also be compensated for the work they're doing. And we have several success stories in that group where they've gone from being in a training academy to getting a small grant to now having 6-figure contracts with the department to do work. And so I do think that pathway for small not-for-profits has been very successful for us there.
So I think one of the things that I learned here was that public health is defined by the public that you're working with, right? So Philadelphia is a city of neighborhoods. Different communities have different needs. So I think one of the successes is we know that the lower northeast sector of the city of Philadelphia, we have one health center there. There aren't that many federally qualified health centers. It's a healthcare desert. So what we have been working on is a host of community meetings, because there are folks, we're trying to build 2 new health centers in that area. So there are folks in one subset of the community that don't want these people coming in their community to get access to health care. They have their access. They don't want these people coming in to have access to health care. This would also help all of our unhoused folks that need health care in the area, because right now it's a healthcare desert. So we had a host of community meetings. I'm a big proponent of creating an ideal speech situation, so having a timer. So there were lots of letters that went to the mayor about how I dinged people and stopped them from talking, but the loudest voice can't be the one that is heard in the room, right? We have to listen to all voices. And so we were very successful last council session. We got both the ordinances passed for both the health centers, and we're working on the funding. So I go around begging for money to just about everybody, because I want both of these health centers to be built up. But that is we banded with the community. They came out, so all of the voices that would have been otherwise drowned out, that had work commitments that couldn't come, we held meetings when it was conducive for them so that they could all attend, and we could create the speech situation so that their voices could be heard as well.
I know many of you still had questions, and I'm sorry we don't have time, but most of our panel members will be out and about during the rest of the time, so feel free to grab them. But I have a sort of last question. These are difficult times in public health, but I don't think in my entire career I've sat on a stage or been on a panel where someone has said, these are really easy times in public health, right? So it's grades of difficulty and grades of challenge. And I think we can all agree, though, these are probably, certainly in my career, the most challenging times. But I also eternal optimist, and I think all of us in public health leadership have to be eternal optimists or we wouldn't get out of bed in the morning. And so when we were having one of our prep calls, one of the things that the panelists said to me that they wanted a chance to be able to share with you is, what are you excited about? At some point we'll come out of this, what excites you about public health and makes you get up every day? I'll start with you, because you're right here.
Okay. Yeah, so what excites me is just my knowledge of history and how every time there's a huge disruption and a huge kind of overturning of kind of our assumptions and our, things that we have just believed or held on to for a long time, or the way we've gone about our business, there's like a painful disruption time, but then out of that, and it sounds sort of cliche, but it's what I hold on to, there comes some sort of path forward. We kind of reset a bit in a way that we need, okay, now let's correct some things we might have done in the past or not done. And so I'm really excited by that possibility and the potential. We just have to see it through.
Great. Palak?
I think what I'm most excited about, one is on trying to work with all the staff for us to get focused and be invigorated and fortified to take care of public health in the city of Philadelphia. And I see that enthusiasm and excitement building. We have 1,688 staff members right now, not counting myself. So having an opportunity to meet with them, which I was able to do throughout the summer, and collaborate with them. But then I'm also a big proponent of actual concrete stuff. So the cool, amazing thing is, yes, FIFA is coming next year. Yes, it's the semi-quincentennial. I've had to practice saying that word. We are the birthplace of liberty, our city. So we are preparing for that. And one of the examples and the exciting thing, and one of my colleagues is here, two of them, and several of them actually, I apologize in the audience, one of the things we worry about is air quality, right? Because it impacts everybody, whether you are housed, unhoused, however. And we have pockets of our city where we didn't have enough meters and monitors to make sure the air quality is safe. And so we have our clarity sensors, which are gonna be located regardless of your socioeconomic status or what have you. We're locating these meters all over the place. They will give us access to data. They will give people access to data about the air that they're breathing. Because while we have a lot of choices on a lot of other things, we all have to breathe the same air. So I think the thing that we're waiting on before to get this completely rolled out is a name. And we'll figure out the name hopefully later today. But that's what I'm really, really excited about to move that forward.
Thank you. Raynard?
I'm super excited about all the work happening at my local health department and also my colleagues. I mean, there's, all the media, the noise you see every day about national stuff, there's a lot of incredible work happening in communities across the country, and that is what I anchor our team in, and I try to remind them. We are doing some really, really great work. We have a lot of threats, a lot of concerns, but the families that we're able to help every day, the environments that we're changing, the neighborhoods that we're transforming, that work is still happening, even though there are threats to funding, threats to other policies. There's still a lot of great work happening to make health possible for residents, and being in a community that supports equity, it is still exciting to have that enthusiasm. And at the same time, excited that we collectively are on the offense and also on the defense and having some successes there too. So there's been funding that's been taken that we've been able to fight and get back.
Yep.
There was holds of funding that at the CDC that were held up for months that we launched a comprehensive media strategy as a Big Cities Health Coalition that we really took a leadership role in doing that to get the funding released. And so there is some fight happening, even though the news may not cover the fight or you might not see it in that way. And so that does excite me.
Great, Dave.
Yeah, for me, ditto, the people. So I came from the healthcare world where most of the doctors I had 60 doctors reporting to me, all of them complaining about their salary because they weren't making $250,000, they were only making $230,000 or whatever. Almost all white doctors, almost all white nurses, almost all black women medical assistants, and just intense racial hierarchy. It was awful. And so to go from that to the Cleveland Department of Public Health, which it just feels like the most diverse, wonderful, committed, cooperative group of people with just this beautiful kind of community mission. Every day I'm pinching myself how lucky I am to be in this role.
Terrific. Well, thank you to our panel. Please join me in thanking our panel. Now, I will say for myself, and probably everyone in this room, I am excited that you are all on the ground and your colleagues in cities across the country. So thank you.
Thank you.